Hi, Alpana is doing great.
Shield, are we alive? Are we live? Sahiti?
Yes, ma'am. We are on live, ma'am. Yes.
Okay. Good evening, everyone. It's my pleasure to welcome you all to the Pinnacle News webinar series, the 12th episode.
Are we alive? Are we live?
No?
Ma'am, we are on live. We are on live.
Sahiti?
Yes, ma'am. We are on live. Yes.
Wait, it's repeating.
1 second.
Good evening, everyone. Is everything okay? Can we proceed?
Yes, ma'am,
Sorry
we
for
can
the-
proceed.
Man, you can
Sorry
carry
for
on.
technical glitches. Yes. So, good evening, everyone. Welcome to the Pinnacle News webinar series, the 12th episode, which is organized by Professor Dr. Sampath Kumari, ma'am. So, this webinar has one very interesting talk and a very informative panel. And we have our chief guest and our guest of honor today to bless us. So, before we start, we'll start with the prayer song and lighting of the lamp.
Audio illa Priya. Priya,
Your
no
audio, please.
No problem with scientific session, Priya.
Can you share Sampath ma'am's TV? Can we have the CV slides?
Just like what is happening to you? Madhumita, just you tell,
Yes, ma'am.
we will start.
So, the Pinnacle News webinar series is brought to us by Professor Dr. Sampath Kumari ma'am, who is a past Vice President of Foxy, and she's also the professor and HOD in at Muthukamal Medical College and Research Center at Chennai. Ma'am is also the current president of Oxy and national corresponding editor of Joggy, and she is the Senate member of Tamil Nadu Dr. MGR Medical University, and she was a past chairperson of Foxy Adolescent Health Committee, and she's received the first ICOG Distinguished Governing Council Member Award, and also she's the chairperson of Women's Wing of IMA Chennai South Branch, and also she's received the IMA National President's Award and IMA Tamil Nadu State Branch Award.
Thank you, Madhumita. So, good evening to all. I welcome you all for this webinar, Pinnacle series. This Pinnacle News, we have named it as Pinnacle News because we have selected the societies from North, East, West, and South. That's the reason it is mentioned as Pinnacle News. This is our 12th series. Today we have the societies Ghaziabad, Bahalpur, Indore, Kota, and Shivamogga and Hassan. I welcome Dr. Alpana and Dr. Chaya from Ghaziabad, and Dr. Viba and Dr. Varsha from Bahalpur, Dr. Sumitra and Dr. Sunita from Indore, and Dr. Patidar and Kumkum from Kota, and Dr. Veena and Dr. Swati from Shivamogga, and Dr. Premlata and Dr. Impana from Hassan OBGN Society, and all the delegates. We have the chief guest, Dr. Archana Verma, and guest of honor, Alpana Agarwal and Dr. Veena Bhatt. Followed by, we have a talk on screening of GDM by Dr. Bharti Rajshekar and chaired by Dr. Kumkum. And followed by, we have the panel moderated by Sumitra Yadav, the GDM and the pre-GDM management, with the panelists, Dr. Shweta, Dr. Vidya, Dr. Chandra, Dr. Aruna, Dr. Raksha, Dr. Suhasini, Dr. Lakshmi Menon, Dr. Priyanka, and Dr. Likita. And I welcome my MOCs, Dr. Madhumita and Dr. Radhika Gauri. Yes, I welcome you all. Without the delegates, the program will not be a success. I welcome all the delegates and the faculties. Thank you. Now we have the CV of Archana Verma. Shri Priya. See, I thank Dr. Archana Verma for accepting to be the chief guest. I called her only 10 days back, I think. Thank you, Archana. Welcome. Archana is Leadership Impact and Awards. What are this? She was the vice president and she was associate member of RCOG, founder president of STUP ISOPOP chapter, organizing chairperson UPCOG, past president of Ghaziabad OG Society, organizing secretary of North Zone Yuva Foxy. That is the first time I met Archana, I think. We were working as a committee chair, and public awareness committee become important only after Archana Verma has taken over. And a member of Rotary and Lions, and Indian Book Award winner. She did a lot of public programs, and only it was Indian Book of Award winner, I think. The President Foxy Best Committee Appreciation Award, UP Governor, RTI, Uttarakhand Governor Appreciation Award for menstrual hygiene. Because of Archana only, I came to know the menstrual hygiene day. That is the May 28th. She did a wonderful program. And Abdul Kalam Excellence Award, Women of the Year Health Award from IAS Wives Association, and the faculty for many national and international conferences. Welcome, Archana, and we need the blessings of you for the success of this webinar. Welcome, Archana.
Thank you. So should I say just now? Okay. So
Yes.
I must say, Sampath, I must say that I have yet to see a person like you. What a great way of working, innovative way of working. Even the name is so unique. And you have invited all the 6 societies, and you have set enough for everybody. And I am so happy to see, especially Ghaziabad President Alpana she's a big shot over here, and she's leading Santosh Medical College, and we are so fond of her also. And this Dr. Bharti, I just cannot say that what Foxy would be doing without Bharti. And now the Madhumita, and you are taking Madhumita also forward. This is something very nice, and you all together, I must say that this academic program, you are too much into the academic, Sampath, and you have given a very good edge to your programs, your work, and a very simple person, very down to earth, and such a beacon of knowledge, and it is an innovative way of inviting people. And I really pray that every participant grow in wisdom, and every discussion is spark new ideas, because GDM is a one thing. India is a hub of diabetes, and so if we do lot of awareness for this, and each and every patient, because all complication start from the simple testing, and if then you can prevent. The prevention is still the number one thing in management and treatment. And wishing this your program a great success, and too much good wishes for your future. I will love to see you as a leading a Foxy, because Foxy is so. I really liked Foxy. And maybe when Sampath is there on board, and then I'll be enjoying a lot. Let's work together under your leadership. Thank
Ma'am,
you.
you are muted. Sambat ma'am, you are muted.
Yeah, I was
Thank you,
thinking that
Archana.
she's happy. She's happy with my
Definitely.
saying.
It's always, I met Archana first in Rajkot, I think, in the conference. Anyway, thank you, Archana, so much. We will do
Yes,
it.
Rajkot was my first conference.
Okay. Okay.
I was quite new to Foxy, and Rajkot was my first conference.
Yes. Yes, still I remember that incident. Thank you so
And
much.
you are truly a friend forever. And even Kalpana, I really miss sometimes Kalpana. Kalpana from Madurai is
Yes.
amazing, a very divine personality. I met her.
Thank you, Archana. Really, we are blessed to have you as the chief guest. Next, we will go to
Thank
the
you.
guest of honor, Dr. Alpana CV. Dr. Alpana, the professor and medical superintendent of Santosh Medical College and Hospital, Ghaziabad, and special awards and achievement, Academic Excellence Award by Santosh University, Best Scientific Activity Award by IMA, Corona Warrior Award by IMA, Ghaziabad, and Global Teacher Award 2021, organized several CMEs as Secretary of Ghaziabad, Organizing Secretary UPCOG 2020, and teaching experience of more than 26 years. Published several papers and articles and chapters in book. And she is the invited faculty in many national and international conferences. Her field of interest is fetal medicine and high-risk pregnancy. Alpana, welcome, and we need the blessings of you. Dr. Alpana?
Thank you, madam. Thank you. First of all, I would like to congratulate you, ma'am, and your team for organizing this excellent webinar. It is the need of the hour, because GTM is one of the most common condition which is affecting almost 50 to 25% of the pregnant females, and it causes significant maternal, fetal morbidity, mortality. It has both long-term and short-term complications, and Delhi being the capital of diabetes, it is said that it is actually the need of the hour. We need more webinars like this, and with people like you who are organizing this, I really thank you. And I really thank you for involving our society. So on behalf of Ghaziabad Obs and Gynae Society, I once again thank you, congratulate you, ma'am. And I'm really honored and privileged to be a part of this webinar today. Thank you, ma'am.
Thank you, Alpana.
And it's so nice to see Dr. Archana also here.
Yes, she's thank you, Dr. Alpana, for the wonderful words. And we'll go to Dr. Veena Bhatt, CV of Dr. Veena Bhatt. Dr. Veena Bhatt is the president of Shimoga Society and chairperson of Public Awareness Committee, Kasoga, and a past secretary of a Breast Committee of Kasoga and chairman PCPNDT, Shimoga district, and winner of Foxy Late S.N. Malhotra Award in 2015, and winner of Shrista Vaidya Sahiti Award from IMA, and the JSSMC Best Alumni Award, and Asia Pacific Excellence Award 2011, Ishwaramma Puraskara by Satya Sai Organization in 2020, winner of Putti Rani Chinnamma Award from Women and Child Department, Karnataka Government, Havyaka Spruti Ratna Award 2024 at International Havyaka Conference, and Navaratnari Sanman at All India Poetess Conference 2025, and Dr. Sunanda Kulkarni Best Manuscript Award in 2024 for the book on PCOS in Kannada at IMA Writers Conference. And she has many awards and invited faculties in many conferences. Welcome, Dr. Veena, for your wishes.
Thank you, madam. First of all, I would like to thank you very much for inviting me and involving our Shimoga Society for your program. And first thing I would like to tell you is I like your simplicity and the knowledge. You are my adorable personality, madam. Because I had not got the opportunity to tell it. Now I have got the opportunity. And you are taking all good subjects only. Today the GDM, really it's a because of changing lifestyle, it is posing a significant health problem, especially in India. As Dr. Archana madam told, it is really posing very much challenges, and prevalence is increasing day by day from 4 to 18%, sometimes up to 20%. And it's a serious concern for the both baby and the mother. So such discussions will help the pregnant and the public, really all the doctors also to be very careful. And I wish all the best and for your programs. And I wish Sampath Kumari madam as our Foxy president, I would in the future, really, I wish her all the best. Thank you, madam.
Thank you, Dr. Veena. Yes, thank you for your best wishes and the words. Now we will move on to the scientific session after that inauguration. Dr. Madhumita?
Yes, ma'am. So now we move on to our scientific session. We have a very interesting talk on screening of GDM by Dr. Bharati Rajshekar. I would like to invite our chairperson, Dr. Kumkum Gupta, to chair the session. Dr. Kumkum Gupta is the Associate Professor of Government Medical College at Kota, Rajasthan. She's also the past treasurer of KOGS, Joint Secretary of KOGS, and she has a field of interest in infertility, high-risk pregnancy, and laparoscopy, and she has more than 10 publications in national and international journals. Ma'am? Kumkum ma'am, are you there? Okay. So, so we have our renowned and eminent speaker, Dr. Bharati Rajshekar, who needs no introduction. She is the medical director.
Madhumita, I will introduce. No problem.
Yes,
Kumkum will join later, I think.
Yes.
Anyway,
Yes,
Dr. Bharati, she is one of my best friend, and she is the medical director and OBGYN consultant in Hassan, Honorary Secretary General, and Indian Red Cross Hassan Director, IMA State Past Vice President, Hassan OBGYN Society Past President, and she has done a lot of Foxy programs earlier itself. Before COVID itself, she has done a lot of Zoom meetings, and Foxy Food Medical and Equipment Drug Committee member, Preventive Oncology Committee member, trainer of Foxy DIRA program, and trainer of Foxy REAC program. Apart from this, me and Bharati has traveled to Israel 4 days. We had a fantastic company and good. She is a nice human being. Dr. Bharati, she will be talking about screening of GDM. Bharati, stage is yours.
Thank you. Thank you, Dr. Sampath, and it gives me immense pleasure to see so many of my dear friends close to my heart here on this webinar. We are more friends and then we are Foxians. So Dr. Sampath Kumari, Dr. Archana, Dr. Alpana, Dr. Madhumita, Dr. Veena Bhatt, we have all been focusing on women's health and trying to do our part in society. And I think Dr. Archana was very right in saying we need a simple, knowledgeable person as a Foxy president. So I wish Dr. Sampath Kumari all the best. She has said we have traveled together, we've been together, and it makes it a more precious webinar for me today. Well, coming to the subject, yes, before we start, I would like to express all our condolences to all those lives we have lost today afternoon to a tragic accident in Ahmedabad. And it is not only the passengers on the aircraft, we have lost a lot of young medical students because the plane crashed into the hostel of Ahmedabad College. So let us pray and may the Almighty give them, their families, the strength to bear this sudden and tragic loss. So with that, let us move on to diabetes, screening of gestational diabetes in pregnancy. And as Dr. Veena Bhatt said, I think a day never passes in any one of our clinics where we don't see a woman with GDM in the present scenario. It is that rampant, and it is not a disease of the rich, or it is not seen only in the urban areas. We very much are seeing it in the rural areas, thanks to the universal screening program that we have all put across. So today I had another forward in Foxy Group, which was talking about a young DNB second year student being thrashed because a baby died in the NICU after being there for 6 days on the ventilator. And the very, very sad incident that she was assaulted. And well, what was the reason for death of the baby was a deeply asphyxiated baby was delivered with a low Apgar and then transferred to NICU, and we did not recover. So when this came to my mind, I thought, could it be a baby which was macrosomic? Could it be a woman who had GDM and maybe the child had its own morbidities? So this is why we need to talk about screening and management of GDM, because these things are so common that this could be the reason for whatever morbidity. I don't know the reason, but this thought came to me, and very aptly I thought, let me mention that in this webinar over here, so that we doctors also need to save ourselves from violence also, and these untoward neonatal and maternal morbidities, so that because maybe it could be due to GDM. So with that, let me go into my topic given by Dr. Sampath today, that is screening of GDM. So screening of GDM. Are my slides visible, Madhumita?
Yes, ma'am. Visible,
Yeah,
ma'am.
I'll make it slideshow.
Yes, ma'am.
Yeah. So now taking this screening for GDM is what we need to do, because we have to nurture the future generation of India. So we have to screen for GDM. And why is it important? You all know that gestational diabetes is a metabolic disorder of pregnancy defined as a glucose intolerance of variable degree with onset or first recognition during pregnancy. Most of the associations go by this definition. And an overview of the situation, 1 in 10 pregnancies is associated with diabetes, and 90% of these are due to gestational diabetes mellitus. That is, it appears for the first time during pregnancy. Undiagnosed or inadequately treated GDM can lead to significant maternal and fetal complications, and women with GDM and their offsprings are at an increased risk of developing type 2 diabetes later in life. This is very, very important. That is maybe the reason we are sitting on this huge tsunami of diabetes today in our middle-aged women is probably because they were fetal in utero programmed to this adult disease, because we were not managing impaired glucose intolerance when they were in utero. So that is maybe those days we were not doing the routine screening and we may have missed. So now I think the time is that we have to see that this adult onset of our fetal adults onset of diabetes can also be managed by proper screening and management of gestational diabetes. So as I already told you, it is impaired glucose tolerance which can occur first time during pregnancy. And I would like to say that 5 pregnant women, 5 out of 10 will be having GDM, and undiagnosed or inadequately treated can have significant complications. So why does this occur? If the mother has glucose intolerance because of the insulin resistance in pregnancy, there is an increased blood glucose levels which cross over in the placenta, and there is an increased glucose delivery to the fetus, which leads to hyperinsulinemia. This insulin tries to reduce the glucose levels in the baby by making it get deposited in the liver and in the fat. That leads to fetal macrosomia, as well as it causes an insult on the islet cells of the pancreas, leading to fetal morbidity and mortality, and later on in life due to adult onset of diabetes mellitus. Okay. So how do we manage? So the guidelines say GDM is considered to be an intersection of two major areas of health, that is maternal and child health, as well as non-communicable diseases. So both are going to be standing on two sides, and we need to address both these issues. So what do we have to do? Optimize pre-pregnancy care with proper preconceptional counseling and care, strive for normoglycemia in pregnancy, track both short-term and long-term problems, so that what is GDM today should not become NCD or non-communicable diseases tomorrow. So we play a pivotal role in managing and preventing not only GDM and maternal fetal morbidity, but also adult onset of diabetes. The Government of India has recognized this issue and brought about national guidelines for diagnosis and management, and the DIPSI, that is the Diabetes in Pregnancy Society of India under Dr. N. Seshaya, has also brought about guidelines which I think are very simple and very easy to incorporate in our daily practice, so that we can reduce this maternal risk and fetal risk of diabetes, which could be polyhydramnios, preeclampsia, prolonged labor, obstructed labor, increased instance of cesarean section, PPH infection, and the babies can have spontaneous abortions, IUDs, stillbirths, congenital malformations, dystocia, birth injuries, neonatal hypoglycemia, and infant respiratory distress syndrome. Well, this will be addressed by in the panel. So now I am going to only speak about screening for GDM. So whom do we test, when to do the test, which test to do, and how to do the test. So whom should we test for GDM? All pregnant women in the population have to be screened for gestational diabetes as per the DIPSI guidelines and the Government of India guidelines. There are guidelines by the RCOG and the ACOG which say screening may be for high-risk population, but we Asians, especially Indians, having an ethnic preponderance of GDM, we need to screen all pregnant women in the population. So that is what the Government of India endorses, and it endorses the single step recommended by WHO by using the 75-gram OGTT, irrespective of the last meal, with a threshold value of 2-hour plasma glucose levels of more than 140 milligrams per deciliter. So when do we test? Universal testing of all pregnant women is needed. You have to do it within the first trimester, preferably at the first antenatal visit. Even when she just gets her pregnancy test, you could do an OGCT and you could do a thyroid and a complete blood count. So preferably within the first few weeks of pregnancy, we would like to do the screening of GDM. But if the reports are normal in the first trimester, you need to do a next screening around 24 to 20 weeks of gestation. However, so as I told you, when should the test be done? The first testing should be done, first antenatal contact, as early as possible. And then you do a second time during the 24 to 28 weeks of pregnancy, even if the first test was negative. I will come to it as to why we do to do the test twice. Why do you think, because there are many practitioners even today who are not screening in the first trimester. They are just assessing the risk and trying to screen at 24 weeks, which sometimes is most often is going to be very, very late. So it is important to ensure second test, as many pregnant women develop blood sugar intolerance during later on in pregnancy. Their first test may be negative, but later on in pregnancy, they are glucose intolerant. And only 1/3 of these women are positive in the first trimester. If the woman comes late and she comes beyond 24 weeks, a single test has to be done. So ideally, first visit, repeat at 24 to 28 weeks. So remember, there should be at least a 4 weeks gap between the two tests. The test is to be conducted for all pregnant women, even if she comes late in pregnancy. If she presents beyond 28 weeks of pregnancy, only one test can be done at the first point of contact. Now, which test? There's so much of confusion, so many guidelines, RCOG, FIGO, FOXY, WHO, random sugar, fasting sugar, OGTT with 50 grams, OGTT with 100 grams, or do I follow the 75 grams GCT according to the DIPSI guidelines? Well, the Government of India and the DIPSI guidelines, which we follow in India, do swear by the oral glucose challenge test. There is a single step using 75 grams oral glucose, measuring plasma glucose 2 hours after ingestion of 75 gram glucose. This glucose is to be given orally after dissolving in approximately 300 ml of water. It can be taken irrespective of fasting or non-fasting state. This is very important because our country having a lot of rural population with very bad transport facilities, it is very difficult for a pregnant mother to reach us in the fasting state. So she can have her breakfast and come, and irrespective of her last meal, the time of the last meal, her glucose challenge test can be done. And the intake of the solution has to be completed within 5 minutes. You cannot give her that 75 grams glucose in 300 ml and ask her to sip it and take it like a ice cream over 10 to 15 minutes. So these small steps have to be taught to our healthcare personnel so that we do not miss or we do not overdiagnose GDM. So how to do the test? Well, keep in mind that 75 gram glucose is dissolved in 300 ml water. They come in a non-fasting or a fasting state. Intake is completed within 5 to 6 minutes. She cannot drink the solution at home and come. Neither can she drink the solution and go home. And the next 2 hours, she will not drink or eat anything except water. There is no physical activity in those 2 hours. So what is the checklist we need to have? Your staff have to be equipped with this. We need to have the 75 gram glucose measured or ready-made pouches of 75 gram glucose. You cannot just tell them to go to the shop and buy something that's 100 milligrams or 82 milligrams and take out 1 spoon. No, it has to be measured. We do get ready pouches of 75 grams. Make them available in your pharmacy. Have a measuring flask to measure 300 ml of water, clean drinking water. See that the glucose is stirred well and dissolves in the water before she drinks it. Otherwise, there could be a sediment which is not taken by her. Have a glucometer with proper calibration, and the coordinating strips have to be there. Of course, the sterile lancet, biomedical waste disposable, and the register for record maintenance. So as I told you, the plasma glucose glucometer should be standardized. And if she vomits within 30 minutes of oral glucose intake, because early pregnancy, they do have hyperemesis, the test has to be repeated the next day, probably after giving her an antiemetic. But however, if the vomiting occurs after 30 minutes, she need not repeat the test. The test continues and you can do the 2-hour plasma glucose assessment with your glucometer, and 140 milligrams per deciliter is taken as the cutoff for diagnosis of GDM. So dextrose monohydrate powder, we do have 75 gram glucose packets nowadays. Do not use glucon C, glucon D, because one, they do have associated other chemicals in them. Second, they are not 75 grams glucose. Okay. And these are the things your outpatient should possess: a stirrer, a glass, and this is very, very important. A plasma calibrated glucometer has to be used so that we can get the results immediately. Okay. And the blood glucose strips should be within the duration of not being expired, and they should be calibrated and compatible with whichever glucometer you are using. And of course, you have the lancets, the biomedical waste, and all this. You have a register for record maintenance and for data production and for analysis later on. And remember, take out the glucose strip from the container and immediately close the containers, because these strips can be biodegradable when exposed to atmospheric air, and always check the expiry date on them also. So I'd make sure the strips match the glucometer you're using, because generally, as you all know, these glucometers have their own compatible strips. So you have to use that, and they should match the number that flashes on the glucometer when the strip is inserted. Do not use old strips. They give inaccurate readings. I told you before, and of course, all of you need this, know this procedure. Turn on the glucometer. This is for your healthcare staff. And then you know that you're going to clean the puncture site with clean swab, allow it to air dry. Do not prick even before the antiseptic or the alcohol wipe is still wet. So wait for that, because they are chemicals which can alter the hemoglobin, and that could in turn lead to fallacies in the reports. So use of lancet should be on the ring or the middle finger after explaining the procedure, cleaning, and then wait for the antiseptic to dry up. Let a good drop of blood to form. Do not squeeze the blood. I am stressing on these points because if we do not teach our healthcare workers these, they will squeeze the blood, they prick with him even before the alcohol is dried up, or sometimes what they do is they don't measure the glucose, they don't see that they drink it in 5 to 6 minutes. All these fallacies can lead to false reports. So let a good drop of blood form. Do not squeeze, because when you squeeze, the RBCs get destroyed. That could lead to unreliable readings. So if the blood is not coming, you can always warm the woman's hand and then try to see that the drop of blood forms, so that you have a single prick and the blood flows out. And of course, all of you know, you keep the strip there. There's a capillary pull on the blood, and the glucometer will give you the result within a minute. Okay. And then, of course, you're going to place the swab over the punctured area, ask her to wait for some time, dispose the lancet and the syringes as per the biomedical waste system. So all the Government of India guidelines says that all PHCs should have an in-house standardized glucometer, and they should do the oral glucose challenge test on the first antenatal visit of any woman who comes to them. 75 grams glucose pouches should be available. Reports should be given immediately. And in case there is glucose intolerance, a reading of more than 140, she has to be referred the same day to the referring doctor who is going to manage her. So as I've already told you, this is what we are going to do. Again and again, I am reiterating on these points because you have to note the time that she is going to drink within 5 to 6 minutes, and then note down the time on the register, and exactly after 2 hours you take the plasma glucose estimate blood and estimate the levels of that. So this I've already told you. If she is vomiting after taking the sugar, if it occurs within 30 minutes, the test will be repeated the next day. If it occurs after 30 minutes, you can always continue to do the test. And after drinking sugar solution, she has to sit for 2 hours. She cannot go and start doing exercises. She cannot say, doctor, I will just go for shopping and come back after 2 hours. What do I do sitting over here? And this is very, very fanciful in our country. They will come there, give the blood, and they'll go wandering everywhere. And sometimes they also have a snack and come back to us. This can lead to erroneous results. And also she cannot just walk about over there. Ask her to just take rest, read a book, listen to music, and then we can do the analysis. So what are the advantages of this very simple DIPSI procedure? It is a simple procedure, easy to execute and implement. No fasting is required in pregnant women. Least disturbance in the pregnant woman's routine activities. Serves both as a screening and a diagnostic procedure, because if the glucose levels are more than 140, you label her as DDM. However, if her levels are above 180 or 200, she would be overt diabetes, and again she has to be managed accordingly. There's an improved quality of life of the pregnant woman once we analyze and put her on medical nutrition therapy or whatever treatment for GDM. There's a reduced perinatal mortality if we identify them early in pregnancy and treat them effectively. There is no hyperglycemia, so there are no associated morbid conditions in the fetus because we have assessed and treated her adequately. And the treatment has shown that the diagnosis with 2-hour OGCT has shown that macrosomia rate has come down very to a big extent, and it is a very cost-effective test which can be done very easily in any small center or in a PHC. So coming to the last 1 or 2 slides, this is the algorithm all of you could put up on your tables, give it to your staff nurses, and say that universal testing is done for all pregnant women in the community. Testing for GDM is done at the first antenatal visit with a 75-gram glucose 2-hour value of a single glucose estimation after 2 hours after taking 75-gram glucose, irrespective of her fasting or non-fasting state. If she is considered positive, if the levels are more than 140 milligrams per deciliter, manage her as GDM as per guidelines. If it is negative, if her 2-hour plasma glucose levels are less than 140 milligrams, you can repeat the test at around 24 to 28 weeks. However, if she is obese or if she has a family history of diabetes, and though her test is negative, you can always tell them that to cut down the sugars, to do regular exercises, to keep a count on their calories, avoid excess weight gain. All these can also be told to them, though the test is negative, especially in risk-positive women. And when you do the repeat test at 24 to 26 or 28 weeks, it is again positive if she is more than 140 milligrams and manages GDM. If it is negative, she is managed as a regular ANC. So if there are any questions, we can take them when the conveners tell us. So let us all work towards having healthy mothers delivering healthy future in our country. Thank you to Dr. Sampath and the entire organizing team of Pinnacle for giving me an opportunity to speak over this very, very important topic. Thank you.
Yes, Dr. Kumkum, are you there? Yes, Bharati, fantastic talk. You have covered all the, always
Thank
we
you,
will tell
Sampath.
that the DIPSI guidelines, fructose, FASTOD guidelines. So finally, you have covered all the screening. Whichever is comfortable, you take it. Like that, I guess.
I think in our country, this DIPSI guidelines is, though there are some studies which say sometimes, but I think if we do it properly, we can definitely pick up most of them.
Yes, definitely we are doing. Now the incidence of the GDM is always increasing due to the lifestyle changes, I think.
Yes,
Wonderful talk, Bharati. Thank you
Thank
so
you,
much
Sampath.
for giving this.
Thank you. Thank you very much.
Okay. We'll go to the next session. Dr. Madhumita.
Yes, ma'am. Yes, ma'am. So,
Come
moving on to our panel discussion, we have to moderate the panel, we have Professor Dr. Sumitra Yadav, who's a professor and HOD of MGMMC and MTH Hospital at Indore. And ma'am is the president of Indore Obstetric and Gynecological Society. And she's also the chairman of MDSR committee in Indore division. And we have, next slide, please. And we have our expert. We have, yes.
Yes, Dr. Sumitra.
Yes, ma'am.
I'm really grateful to you people for including me here, but there is some issue with my phone. I'm unable to do the slide share.
You
And
send
neither-
it to me. I will share. Sumitra, you can send it to me. I will start sharing.
Okay.
In the meantime, she has introduced the panelists.
Yeah.
You send it to me. I will share in the, or share, put it in the group.
Yes, ma'am. So, as an expert for the panel, we have Professor Dr. Sampath Kumari ma'am, and we have our esteemed panelists, Dr. Shweta Kalja, who is the Director of Nirmay Care Women's Center at Indore, and she's also the Vice President, Indore OG Society, and Managing Committee Member of ISAR and Joint Librarian of MP ISAR. We have Dr. Vidya Santosh, who is the Senior Consultant in Reproductive Medicine and Fertility Specialist at Sarji Fertility and Research Center at Shimoga. She's also the Joint Secretary of Shimoga and EC member of Reproductive Endocrinology Committee, and also of Kasoga, and past EC member of Shimoga, and patron member of PCO Society of India. Welcome, Vidya. And we have Dr. Chandu Shri, who's now currently working at Kadur General Hospital, and also she's also attached to SSIMS Chaitanya Trust. Next, we have Dr. Aruna Patel, who's a obstetrician gynecologist, infertility consultant, and also laparoscopic surgeon, and director of Vatsalya Mother and Child Care Center at Indore. And she's a life member of IAG and IMA. Dr. Raksha Sharma, who's a director and senior consultant at CFH Clinics and vice president of Kota Obstetric and Gynecological Society. And she's also the master trainer of HPV vaccination program by Foxy. And she is a member of National Academy of Medical Sciences and member of Foxy, IAG, PCOS, and NIGF. Dr. Likita Krishna, who works at the Taluk Hospital at Hassan and joint secretary of Hassan Obstetric and Gynecological Society. Dr. Priyanka Maheshwari, consultant at SN Parikh Memorial Hospital and Nari Care Hospital, Kota. And she's also the member of organizing committee member of West Zone Foxy in 2022 and joint secretary of KOGS. Dr. Lakshmi Menon, who's the assistant professor at Muthukumaran Medical College and Research Center, Chennai. And she's also the member of Calicut Obstetric and Gynecological Society. Dr. Suhasini Karnal, who is a consultant and working as an associate professor at
Ma'am, Sabat ma'am, I think madam's line is okay.
Yes.
Yes.
Madhumita, how many of the panelists have joined?
Ma'am, Dr. Vidya has joined.
Dr. Vidya,
Dr.
Dr.
Suhas,
Shweta,
Suhas,
Dr. Lakshmi.
Shweta. Yes, ma'am. Dr. Shweta is in an emergency. Ma'am has joined. Actually, she's there. Shweta ma'am has joined.
And Lakshmi
Dr.
Madam
Suhasini
and
has joined.
Subhasini is there. I
Yes,
think
ma'am.
can we include Swati Kishore? You are there, and Dr. Swati Kishore, can you join as panelist? Anyway, we will start projecting. Sumitra? 1 minute.
Yes, madam. Yes, madam.
What happened to the presentation?
Ma'am, next is a empty slide. Next, you can just go.
Next slide.
Yes,
Next.
yes. Yes, Sumitra, Dr.
Yes, madam.
Dr. Sumitra, the panelists are Dr. Shweta Jha, Dr. Lakshmi Menon, Dr. Suhasini, Dr. Vidya Santosh.
Okay.
Others, I think they must have been some emergency or I don't know. They have not joined. We will finish with this 4. Yes, Dr. Sumitra. you can
Firstly,
start.
let me thank you for including me in this panel, in this webinar, and asking me to moderate this webinar. And it is such an important topic, diabetes in pregnancy. So I've just kept 2 patients. I hope everybody will be happy. Now, without much ado, Dr. Shweta is one panelist, isn't it?
Yes, Shweta Jha is there.
So I wish her the best of luck for this time's elections, and to you, for the next time elections. I'm quite confident about you both. Now, the
Thank you.
first question is Mrs. X, a 30-year-old primi gravida at 28 weeks gestation. There is no prior history of diabetes. The BMI is slightly more. If you see, she's 32, has 32, and has a family history of type 2 diabetes. Now, during the screening, we find that her OGCT is 160 milligram at 2 hours. And then we got a follow-up done. The 3-hour 100 milligram glucose tolerance test shows elevated values of at fasting and at 1 hour. Now, Shweta, do you see something? Would you become alert right now?
Yes, ma'am. Her 75 oral glucose tolerance test itself is like 160 milligram, ma'am.
Yes.
So it is hinting towards I mean, more than 140 is something which needs to be evaluated.
Yes.
So she and the OGTT shows elevated values at fasting and 1 hour. So we can label her as diabetic, and she has a family history also. If she's Asian, she has ethnicity risk factor also.
Mhm.
So
So
this is
what
28 weeks
what will be,
gestation. Okay.
what
She had
what
quite late the screening done, I suppose.
no, basically, see, we get cases in the medical college at the end. We get at any time. So when we get, we start with the things. Okay. So now this patient has come to you. This is her first visit, and now these are the values. What will you do?
Ma'am, I'll take physician opinion, and depending on the opinion, we'll put her on mostly insulin because she's already 28 weeks.
Okay. Why insulin, may I ask?
We can put her on meal plan actually, ma'am. It's only 160. We can put her on meal plan and then repeat the fasting and postprandial after 2 weeks. And if it
What
is,
will you meal plan?
pardon, ma'am?
Mm-hmm. Yeah.
We put
Good,
her on
good.
Yeah. And then we'll repeat the fasting and
Hello?
postprandial
Can't
after
hear.
2 weeks. Yes.
So what will be
Am
the
I
plan that you'll be putting her on?
no,
Study
split of
therapy.
carbohydrate meal and limiting the carbohydrate meal
Okay.
and splitting the 3 major meals into portions.
Yes.
And then physical activity also can be added.
Yes,
Exercise.
increasing physical activity, but not
Yeah.
at the cost of her getting tired because
Yeah.
she's already 28 weeks gestation.
Yeah. Yes, ma'am. And then we'll repeat the fasting and postprandial after 2
And
weeks,
the
ma'am.
third, okay, after
2 weeks.
and you will be keeping her under vigilance. So
Vigilance.
who is the third? Who is the third
Dr. Vidya
panelist?
Santosh.
Yeah, Dr. Vidya Santosh, would you like to do anything else at this stage? She's 28 weeks. You just have her glucose test with you. Anything else would you like to do?
Ma'am, I have to get her done for means ultrasound scan has to be done for her.
Mhm.
Whether it was done prior or like we have to check for her the fetal because along with the mother we have to check for the fetal status also.
Yeah.
Whether for polyhydramnios or is there any whether because it's the first time she has been checked, we don't know from how long her sugars have been high. So
Yes.
we have to assess the fetal well-being because whether it's severe baby has gone for IUGR or whether it is like uh, fetal size it is on a higher side, we have to assess the this thing also. And we have to tell her proper monitoring of her sugars at home also, strict monitoring.
Right. Right.
If she can afford a glucometer at home, it would be good because now it's such a
She
affordable
has to
price.
have a glucometer at
Yeah,
home. That is mandatory for this.
mandatory.
Yeah.
Yes. And she has to be in regular touch with her obstetrician. And she has to update her weekly charts. That would be good. And along with that, we do have to include a dietitian uh, to give her a proper diet chart. Along with an, I think we can keep in touch with our endocrinologist also, who can.
Tell me one thing, would you do a physical examination, obstetric
Yes.
examination, or will go straight away for the ultrasound? Nowadays,
No,
gynecologists have
no.
ultrasound. So they do the ultrasound and don't write anything regarding the physical examination. I wanted to stress that don't bypass the physical examination. You are an obstetrician, not a sonologist. So first
Yes.
see the patient physically, do the testing of fundal height and everything, and then switch on the ultrasound probe because that also needs to be written. You are writing the fetus. Now, I'm not telling about you. I'm just telling the common gynecologists nowadays. They write everything about the. We have ultrasound reports, number of ultrasound reports, but not the physical examination. We cannot bypass that. That's very nice what you have told me. Now, after 2 weeks, as they said, if her sugars have not decreased, what would you do? You are in a standalone CHC, or your medical doctor has moved out. He's gone for a conference. Now you did this, and now you don't know what to do. The patient is not ready to move. The next
We
panelist.
can admit her. Yes, ma'am. We can admit her, monitor her blood sugar levels, and we can start her on insulin. After
I would like
monitoring
to
of the
ask
sugars.
you. I would
Yes.
like to ask you that admission costs and
Okay, ma'am.
patients.
If she's not
Patients
willing for
expect
admission,
miracles. Once you admit, they want miracles from you.
then
So
also home monitoring can be done, and we can start her on
somewhere
insulin also.
counseling is very important here. Unless
Yes,
and
ma'am.
until you counsel her, you will tell her don't eat this. She'll go on eating that because the mother-in-law will tell if you will not eat, your baby will not be good. So counseling, role of not only nutritionist, the role of counseling also.
Counseling.
Apart
Yes.
from this, any idea about Suhasini? Would you think
Yes,
about metformin anywhere?
Metformin, actually, the control of sugar levels will be better with insulin, ma'am. And
Okay.
And if it is a gestational diabetes, I think it will respond more with the insulin. It will be better to go for insulin because there are complications, maternal and fetal complications are more with gestational diabetes if the sugars are not controlled well.
Very true.
So I would prefer going for a low dose of insulin rather than metformin.
Anybody differs with the statement of Suhasini?
Madam, can I talk, Dr. Sumitra, Dr. Bharti
Yes.
here?
Yes,
So I think, so madam, in our setup, we can still, this metformin still does have a place in management because she has come late in
Yes.
pregnancy. So the fetal, if there is any anomalies or something that would have identified by scan, but in our scenario, when our rural women are not able to take insulin, metformin can still be used. I do use.
That's what I wanted to tell. Again, that's why I was asking this,
Yes.
because although the sugar may be raised to 160, that doesn't mean that we don't use the standard drug of metformin. That does have good results, and less monitoring is required, less scheduling her for insulin doses. What I've seen is in many patients of even the urban background, they'll take one insulin, they'll not take the other one. This is according to their whim and fancy.
Yeah, and they don't
So
take
these
it
things
according to time. They don't take it according to the time also, 8-hourly or
Yeah.
whatever we tell them.
So you must actually see the patient according to her education status, according to her ability to understand your what you are explaining, and you must also look at the patient as a whole. So follow up, of course, as I've told you, serial growth scans and antenatal testing, other things were also required. One thing that I would like to stress is that would you like any other test? Would you be alert for some other test in such patients? Dr. Shweta? Dr. Shweta? Dr.
Lakshmi Manan will be there. I think Shweta is not there.
Vidya is
Lakshmi?
there. Dr. Vidya.
Dr. Vidya is there.
Dr. Vidya,
Yes, ma'am.
can you tell me what would you like to do in this patient? Because we know that this is this thing. Would you like to screen her for something else? That is very important.
Retinal screening.
Yeah, retinal,
That's
and
yeah.
that all you will
And
do for the
yeah,
diabetes patient. That
yeah.
retina, nephro, that is creatinine, and all that you will be doing. And retina is a very important thing. But would you think of something simpler?
Acrosomia.
Something simpler.
Mhm.
We always talk about recent advances, but what is the basic we are not forgetting?
Amniotic fluid index, and when we're looking at the scan, we should look for if there are any complications for the baby also. If there's any macrosomia,
Yeah,
polyhydramnios.
yeah. Very nice. But
Any
apart from the scan,
urine, ma'am? Urine
apart
routine to check for any
Eclampsia.
infection.
PIH screening.
apart from the scan, any other test would you like to do?
To rule out associated preeclampsia or hypertension.
Anything else?
Urine routine itself, ma'am. if
Yeah,
there's a-
that is
yeah.
the thing. In diabetics, always get the urine routine done. Why? Why is it so?
Chances of recurrent UTIs will be there,
Yes,
which they are not,
very true.
and along
What
with
else?
candidiasis.
What
If we
else?
can
Very
find
good.
any ketone bodies or like
Yeah, that ketone bodies tells you what is actually, because she may be saying something and you may find certain, innuendos by which you can diagnose that what is the issue. Why are we worried about candidiasis? Why are we worried about urine routine?
candidiasis because if the sugars are uncontrolled, if it's there for a long time, there are chances of preterm labor, PPRM, if there is
Yeah.
any recurrent UTIs.
And we know that what is the issue with the lungs of the baby?
ARDS, more prone for ARDS.
Maturity.
Yeah.
Lung maturity happens at a later stage in GDM. So
Very correct. Very correct. So now she's 28 weeks. What you can think of? Because we don't know when she'll deliver.
they will have
Something-
to think of giving corticosteroids for
Yeah.
lung maturity.
Which one would you prefer? Which one would you prefer, ma'am? Suhasini?
Dexamethasone.
Dexamethasone. Why dexa and why not betamethasone?
So both can be used, but then dexamethasone
Uh-huh.
is preferred.
There was preferred in the hospitals. Which were hospitals?
Hello, I couldn't get what you were telling.
Sumitra, they are telling that they will give dexamethasone.
Okay. Now you have given dexamethasone and the patient delivered at 39 weeks vaginally. And postpartum, 6 weeks later, the fasting sugar is 105 and 2 hours is 165. Now what do we do? Madam, can I have the next slide? Lakshmi?
If the sugars are increased, we should follow up. We should do an HbA1c and also continue the patient on treatment. Refer them to a physician, and patient should be kept on monitoring as well.
Okay. The other girl, she wants to differ. She wants to add on something.
Vidya,
And
Vidya?
we can continue monitoring her at
Bharti
home
want to
itself.
tell you something. Bharti?
Says repeatedly we are hearing that please I will refer to the physician. I think we as obstetricians should learn to manage GDM. We can take the help of the physician, but it is not always very feasible, because I think we should manage GDM as obstetricians, because we have the very good guidelines available.
Absolutely true. Absolutely
Yes,
true. Bang on. This is
Yes.
what I wanted to come at. That why should we think that we cannot manage this?
Exactly.
After all,
Yes.
30% of the population is about to be diabetic. And if we'll not be managing this, how long will we be dependent on somebody else?
Yes.
That's why I kept this
Physicians
case.
will not bring in a
I think
tight
the
control
intention
of
Dr.
glucose
Sampath has this webinar is every obstetrician should manage GDM, every obstetrician should manage hypertensive disorders of pregnancy on
Yes,
their own.
definitely.
If there are complications,
Absolutely.
you ask for help.
Definitely.
you
GDM
should
is always
always,
managed by obstetricians.
yes, you should always ask for help. Document it for your cases that you have taken an opinion, but you can't be asking them to titrate everything.
Exactly. Yes, yes.
Their titration also will be different, ma'am. They will bring down the sugar in a gradual way, wherein we need a tight control for the to avoid the complications also.
Yes.
But the physicians will not bring it.
I'll tell you one thing. When the baby is being fed, that will also reduce her sugar levels.
Levels, yes.
Glucose
That is
levels.
also there. You have to take that also into consideration. Can I have the next slide, please?
You have
Now,
the
these are the
yeah.
important things that I had told. That one is counseling, one is lifestyle changes, yearly screening for type 2 diabetes, breastfeeding. I've already told you it benefits the glycemic control, and of course, family planning, that is important for her. And you have to avoid estrogen containing methods because of her poor glycemic control. Next case, please. Now, she's a 34-year-old gravida 2 para 1 with a history of type 1 diabetes since 14 years of age and currently is 8 weeks pregnant. The past obstetric history is 1-term vaginal delivery. The infant had macrosomia. Why I have labeled it as macrosomia at 3.8? Because in Indian women, 3.8 can be
Macrosomia.
NICU admission for hypoglycemia. Now she is on insulin, both insulins, and her recent HbA1c is 8.2. This was measured 2 weeks ago. And her BMI is 29. The comorbidities include mild background of diabetic retinopathy diagnosed a year ago. Next slide, please. Now, what points should be considered during preconception counseling? Not preconception, you that this patient was
Yes, Dr. Vidya.
Hi, ma'am. Main thing is the HbA1c level, which is 8.2 right now. Actually, we should think about keeping it low by at least less than 6.5
Yeah.
minimum. And she should at least be started with folic acid preconceptionally, I think 5 mg, at least according to me, for at least 3 months. 1 month, as mentioned, it's fine. And she had a last retinal checkup around 1 year ago. So at least it should be within the last 6 months, it would be better. If she has not done it, she should consider it getting done before conceiving. And till then, but already she is
Can't hear you. Can't hear you.
Vidya, put off your video and talk. It will be audible.
Yeah. Can you hear me?
Yeah.
Yes,
Yeah.
yes.
Okay. What's the gestation age, ma'am?
She's
Gestational
6
age
weeks,
is
no?
Yeah, she's 8
weeks.
8 weeks.
8 weeks.
6 or 8 weeks, early pregnancy.
Okay. If she had, can I see the slide? She required this one. What retinal examination, which
Yes, definitely.
So she has
Hello.
mentioned about the folic acid. Yes, Bharti.
And you have to see the
Sorry.
fasting and postprandial values also, how her sugar control is at present. And other organs also have to be screened, like renal and renal function test and this thing, because already she's developed retinopathy. So we have to screen for other organs also, because she's a known case of type 1 diabetes.
Very true.
And the current blood sugar values have to be monitored, like fasting and postprandial also, because sugar control is very important in the early pregnancy to avoid the neural anomalies, cardiac anomalies. And folic acid as preconceptional, she should be started.
Yes, Bharti.
Well, Dr. Sampath, what preconceptional care was Dr. Sumitra asked us. So I think we have to be very, very particularly counseling the family along with her husband, because she already had a macrosomic fetus and she should have been counseled on lifestyle. She should have been told to control her blood sugars and bringing the HbA1c lesser than 6.5 before she became pregnant. And along with that, as Dr. Subhashini said, her renal function tests, her retinopathy, all her end organs should have been assessed. She should have been put on folic acid and her complete blood count seen. If she's anemic, her anemia should have been corrected. She should have put on vitamin D, asked to reduce her weight, come down to an optimum BMI, and then she should have embarked on pregnancy. So we should have told her that if you have a HbA1c as high as 8.2, your baby will not only is at a high risk of congenital abnormalities, but also your fetus is going to be programmed for adult onset of disease. So this is where we can catch them and tell them, if you don't control your sugars preconceptionally, your child is also going to land up with diabetes. And that strikes a bell and they listen to whatever we say. I think this, as clinicians, all of us need to give proper counseling before she embarks on her second pregnancy.
Yes, as Dr. Bharati
This
told.
absolutely true. Since she was
Yes, Sumitra.
Physician should have told her
Yes.
that before embarking on any of the pregnancy, this all should be taken care of. Nowadays, we are seeing more cases of Modi. So we must also that these patients have to be controlled like that. Of course, the next slide, please. This we have talked about. How will you manage? Next, please.
This all
this, I think we have talked.
Yes, fetal echocardiography at 18 to 22 weeks type 1 is very important.
Yes. I would prefer that in diabetics, there should be another echo between 20 to 22, because at times at 18 to 20 weeks, the heart chamber, the valves may not be that clear. So it is always best that we do it a little late. And what are the glycemic targets? Next, please. I'll make it easier for you.
Fasting should be less than 95 and 2-hour postprandial less than 120.
Sumitra,
Next,
are you
please.
doing the 3 values or 2 values in your hospital?
Two values, ma'am. We just do 75 gram and then
Two values.
2 hours after. If required, then the DIPSI guidelines. What will the further management in pregnancy, Dr. Lakshmi?
After we do a 20 weeks, we should do a detailed anomaly scan. 24 weeks, we should do an echocardiography. Afterwards, we should keep on monitoring the sugars, and as long as the sugars are well controlled, we can terminate the pregnancy after around 38 weeks after steroid coverage and all. However, if the sugars are not controlled, then termination should be planned by 37 weeks.
In type 1, respond to
insulin.
Yes, Sumitra is. So now the sugar is controlled and with the pre-GDM. What are all the possible maternal complications, Dr. Vidya?
Ma'am, chances of having hypoglycemic episodes because she will be on insulin, the most common one, or along with chances of diabetic ketoacidosis, and chances of worsening of, as usual, retinopathy, and increased chances of PAH will be there. And there will be chances of when it comes to the during the during delivery, she will be chances as already she has had a previous macrosomic baby, chances of having a this one large fetus and shoulder dystocia and all the UTI chances will be more.
This is maternal complications. Dr.
Yes,
Sumitra,
ma'am.
can you take over?
Yeah, connect. I don't know what's wrong. There is something that has gone
No
wrong.
problem. Without the video, you can talk.
Trying my
Now
level
you.
best. No, you can hear me?
Yes, maternal
Hello.
complications, they have finished it. Now coming to the, yes, Sumitra.
Yes, I can't see.
You cannot see the slide? What are the possible fetal complications? Dr. Lakshmi Menon?
Fetal complications
It
include
is a case of pre-GDM, no?
GDM number one, there might be anomalies. So even after birth, we have to screen the baby in detail from head to toe to make sure that there are no anomalies. Then infant of diabetic mother, they have a higher risk for hypoglycemia, hypocalcemia, higher risk of respiratory distress syndrome, necrotizing enterocolitis. So we have to screen for all these things. They're also at a higher risk for sepsis. So we should keep a lower threshold for that.
Can Suhasini can explain the shoulder dystocia now that you are delivering the baby, the head that comes with the turtle sign, and how will you manage this shoulder dystocia?
Can put her on hyperabduction and hyperflexion of the thighs. This is Macrobert's maneuver. Can apply suprapubic pressure and hyperabduction and hyperflexion of the thighs. If that fails, then we can go for Wood's corkscrew maneuver. And we have other maneuvers also to bring out the shoulder and then the baby. So chances, we have to also look for chances of brachial plexus injury, clavicle fractures, and humerus fracture.
Yes,
I would suggest that given in the today's scenario, it is best to anticipate such complications and to avoid going for vaginal deliveries.
Yes.
Rather than going for these maneuvers, you should only try these maneuvers if you are caught in that.
Yes.
But for
Hello,
type 1,
am I audible?
Yes, Sumitra, you are
Hello.
audible. Proceed.
Yeah. So, how will you plan the delivery in these cases?
Yes, Sweta.
Hello.
Sweta is there now. Sweta Kalja. If she's not there, Vidya can take up. Madam has
Shweta's phone, Shweta ma'am's phone got switched off, it seems, ma'am.
Then Vidya, you can take up. Yes,
If you're
Hello.
planning for vaginal delivery, the morning dose of insulin can be skipped, and we have to monitor her sugar values also in the later phase of the labor. And first of all, we have to decide on whether we are going to allow her for a vaginal delivery or a cesarean section. On an ultrasound, if we find it is a macrosomic baby or the fetal weight is more than 3.5 or 3.6, then we can plan for an elective cesarean section. Otherwise, if you are planning for
Very
vaginal,
good.
then we have to monitor the sugar values. And if it is high, we can put continuous insulin infusion depending
Yes.
upon sugar values.
What will be the time when you will plan her delivery?
If it is well controlled, then we can plan delivery at 38 weeks, because 38 to 39, or because the complications are more and chances of IUD are more when we allow her to
Yeah,
go
because
past
many
38
places I have
weeks.
read that they say that at 40 weeks, but the threat of IUD looms
Very
large.
high.
It's preferable that once the lung maturity has been achieved, you remove you allow the
We
baby
have
to
to
be
plan for
born.
delivery.
Now,
Yeah.
what points need? Yeah, you must plan according to that. This is my last question. What points needs to be considered in the postpartum care?
We have to
Yes,
monitor
we
her
have
sugar
actually.
values, and we have to look for
Hello.
hypoglycemia
Hello.
also. Yes, ma'am. Audible?
Yes, Sugasini.
Yeah.
So we have to monitor her sugar values post delivery. Post delivery, her sugar values may drop down, so we have to keep on monitoring her and adjust the dose accordingly. And also look for hypoglycemic episodes. Also, we can initiate breastfeeding, and we have to also advise on the contraception. And chances of wound infection are more with type 1 diabetes when the uncontrolled sugar values are there in the antenatal period. So if it is a vaginal delivery, the episode of
Absolutely.
wound should be taken care of. And say cesarean section, the post-operative wound should be more seen. And third day, you can see the fasting and postprandial to look for the sugar control. Then contraception counseling has to be given.
Mhm.
Yes.
And actually be alert for infections also. These people have infections in the
Yes, ma'am.
episiotomy site, urine. So you have to
That's
be
what I
very
mentioned,
alert.
ma'am. Yes, ma'am.
Thank you very much for answering so well. I would like to thank Dr. Sampath Kumari for giving me this chance. Thank you very much.
Fantastic, Sumitra. Good moderation and with the good interactions of the panelists. Really, the two cases, the GDM and the pre-GDM, wonderfully tackled by Dr. Sumitra. Now we will go on to the vote of thanks by Dr. Madhumita.
So coming to the end of this wonderful session, it is my honor to give the vote of thanks today. So I thank our organizer and convener, Dr. Sampath Kumari ma'am, for bringing us this excellent webinar series. I thank the presidents and secretaries of Ghaziabad Obstetric and Gynecological Society, Bhagalpur Society, Indore Society, Kota Society, Shimoga and Hassan Society for your presence and your valuable time. I thank our chief guest, Dr. Archana Verma, guest of honor, Dr. Alpana Agarwal, and Dr. Veena Bhatt for your blessings and wishes. Our chairperson, Dr. Kumkum, and our excellent speaker, Dr. Bharti Rajshekhar, for sharing your insights. I thank our moderator for the panel, Dr. Sumitra Yadav, and our esteemed panelists, Dr. Shweta Kalja, Dr. Vidya, Dr. Lakshmi Menon, and Dr. Suhasini Karnal for sharing your insights and your valuable time. And I thank Shri Priya and Sheel Connect for technical support, and all our delegates for joining us today here. Thank you again, one and all.